gorgeous, gorgeous girls and guys. Welcome to my channel. For those of you who are new, hello, my name is Brianna, aka Dollface PA. I can be found at Brianna Moore on all social media platforms. For those of you who are returning, thank you so much for coming back. I know that I have been posting a lot of various content on my channel lately. There is a reason for that. But today I'm going to get kind of back to the academia, which is what I initially founded my channel on. So I'm going to be specifically discussing the 5 most common diagnoses that I see as an internal medicine hospitalist PA. And I think this could be very useful and insightful to maybe a new grad who is still not completely sure what field they want to go into. I'm just going to give you a brief insight as to what you can expect to see a lot of if you decide to go into internal medicine hospitalist. And this is something that I didn't know going into hospitalist medicine, so I hope you guys will find this useful. Quick disclaimer, I am going over the 5 most common diagnoses excluding COVID-19, because obviously if I included COVID-19 in this talk, it would override everything else. So pretending like COVID-19 doesn't exist, these are the other 5 most common things that we see in the hospital and why patients are admitted to the hospital. The number 1 thing I would say is syncope. For those of you who don't know, syncope is just a transient loss of consciousness when you pass out or you done fell out or whatever you want to call it. And a lot of people syncopize for various reasons. They'll come into the emergency room like, oh, they'll bring in their elderly mother, like she passed out and she was out for 5 minutes and then she like woke up and didn't have any recollection of what happened. So a lot of those patients get admitted to the hospital just for monitoring and workup to try to figure out like, why did this happen? The workup will typically consist of, if there was a head strike, they'll get a CT head just to make sure that there's no brain bleed in the head. They will be admitted to telemetry to monitor the heart just to make sure there's no arrhythmia that could be contributing to what happened. We'll do orthostatic vitals to make sure the patients are not orthostatic. That just means they're dehydrated. Sometimes that can lead to syncope. Oftentimes we will do an echocardiogram, which is an ultrasound of the heart, just to take a look at how well the heart is pumping, take a look at the valves, make sure there's no wall motion abnormalities. Of course, we'll get an EKG, troponin, make sure that this is not a cardiac etiology in nature, and we kind of just go from there. In some cases, it's as simple as dehydration. In other cases, it's a little more complex, like, oh, the patient has new AFib, and so we have to calculate a CHA2DS2-VASc score and see if the patient needs to be anticoagulated. And so it kind of just goes from there. So syncope is a really big one that we see a lot. And almost always, if it's an older person that is a little bit more frail, they will be admitted to the hospital for further workup. So I hope you like syncope if you want to go into hospital medicine. Number 2 would be heart failure exacerbation. A lot of patients have congestive heart failure. And so when they go into an acute exacerbation, they're often admitted to the hospital for IV diuresis. Many of them take Lasix, which is the water pill at home. But once they're in an acute exacerbation, they require IV Lasix, which does require admission to the hospital. So usually we will diurese them. Sometimes we will repeat an echocardiogram, which is the ultrasound of the heart, just to make sure that nothing has changed from their previous echocardiogram. And that's pretty much we do daily weights, strict eyes and nose, just calculating the inputs and outputs to make sure that the patient is diuresing appropriately. And once they have return to their dry weight and they're feeling better, clinically they're looking better, there's no like peripheral edema or no respiratory symptoms such as shortness of breath or anything like that, they're usually able to discharge home. Number 3, ACS rule out. So when somebody comes in for chest pain, usually they're going to be ruled out for acute coronary syndrome. And so they'll often come in through the ED. They come in with chest pain or whatever the story may be. I was walking down the street and then I had this chest pain. This felt like an elephant was sitting on my chest. Of course, the number 1 thing you have to rule out is a STEMI, which is the most dangerous type of heart attack that somebody can suffer from. So down in the ED, they automatically get an EKG. They get troponins, which is a blood test used to see if the patient is having an active event in the heart. And sometimes those things are a little equivocal. And so the patient is not ruled out for acute coronary syndrome and therefore are not really safe to just discharge home. So they will admit them to our service for either telemetry monitoring, continuing to trend troponins, probably another echocardiogram of the heart. If you can't see the trend here, a lot of this involves cardiology, which is why I was saying in my other video, cardiology is just such a huge part of medicine when you're going into a general medicine field such as hospitalist. And that's why it's so heavy on the pants, and that's why it's so important that you understand it and know it, because a lot of the diagnoses that we see in the hospital go back to cardiology in some way. And so depending on, let's say if the EKG has T-wave inversions, the patient may require a stress test where they get on the treadmill and we do EKGs and look at an echocardiogram while they're exerting themselves to see if we can like reproduce these changes on the EKG. If it's a positive stress test, then they will proceed to cardiac catheterization, which is when they put a catheter through either the wrist or the groin and they actually go in to look at the coronary arteries on the heart. They can put in stents to open up blockages or so forth. So it's both diagnostic and therapeutic. So ACS rule out is a huge one. You will be heavily in conversation with your cardiologist to coordinate these additional tests if the patient needs them, such as stress test or cardiac cath. Number 4, alcohol withdrawal. And so I'm sure this will probably vary depending on what neighborhood you work in, but the population in which we serve, we see a lot of alcohol withdrawal. A lot of the alcohol withdrawal patients on our service are very well known to our service. They are admitted to the hospital all the time for alcohol withdrawal. And we basically admit them to our service and we monitor them and we give them Librium and other benzodiazepines to treat the withdrawal. And what we are really trying to do is make sure that they don't have very bad consequences from the withdrawal, such as withdrawal seizures or DTs. Those things can be life-threatening in a person with withdrawal, and that's why it's very important for them to be admitted and monitored very, very closely. So we see that all the time. Alcohol withdrawal is a huge one. And lastly, number 5, social reasons. So this is the thing they don't tell you in PA school, is that a lot of your job is not going to be medicine. So a lot of patients are admitted to the hospital simply because of their living conditions at home. A lot of the time, elderly people who can't really care for themselves anymore will come into the hospital and it's like, oh, well, this patient has like rats and roaches all over their house, like they're like soiled in their own feces and urine and they just can't really take care of themselves anymore. So they come into the hospital, and although there's not a medical reason for admission, our social work team works very closely with the medical team, and our social work team will help to find a place for this patient to go next. Whether that is a nursing home, a subacute rehab, whatever the situation is, it's more so for placement as to a safe discharge of where the patient is going to go next than it is an actual admission to the hospital for a medical reason. So that's a big one, because there's a lot of conversations with family and goals of care conversations depending on the health of the patient and where the patient is in their stage of illness, if there is one. And so that is something that I never really expected to encounter working in medicine, but it's something that we see every day, and I'm honestly very well versed in it now. So just a quick video on 5 things to expect should you decide to become a hospitalist PA. If you have any questions, please don't hesitate to hit me up in the comments, email me, hit me up on Twitter, hit me up on Instagram. I respond to everybody. Let me know if you want me to dive any deeper into this topic. I'd be happy to. And thank you so much for watching. I'll see you guys on the next one. Love you guys.